Good afternoon, everyone, and bonjour. Welcome to the second End FGM EU Research webinar series. I hope you are all well. You're all looking very well and nice. And I hope that you are coping with the COVID-19 conditions in all your respective countries. I also hope that you and your loved ones are safe and that everything is going well as best as we can. Just a bit of background, at the End FGM European Network, we value very much enriching exchanges with researchers to advance on our collective work to ending FGM and supporting survivors. To this end, every year we cooperate with academics and researchers to ensure we bring new input to our work and have a collective reflection on specific topics that can help bring out joint efforts forward. Last year, we hosted a presentation of Dr. Sarah Johnsdotter on her research on stigmatization of FGM affected communities in Sweden, as well as one on reconstructive surgery with Dr. Pierre Foldes and Dr. Anne-Marie Middelberg. This year, we have also had two research webinars, the first of which took place last week with Dr. Sarah O'Neill discussing pleasure, womanhood, and the desire for clitoral reconstructive surgery at Semavi FGM Reference Clinic in Brussels. And today is the second. So today I am honored. I'm very excited to welcome four excellent researchers who will guide us through a very crucial topic in our work, which is about collecting accurate data on FGM prevalence in Europe. I'm sure we are all aware, but if we are not, we'll find out that data collection is a crucial issue and a major challenge while working on FGM. And we always advocate to improve the available indirect estimates on FGM in Europe through more rigorous methodologies and consistent methods across countries. But how do we do that? During this webinar, we are going to go on to explore different methodologies used in different studies in 4 European countries to research FGM prevalence. And we'll have an open discussion about methods, pros and cons, including challenges, shortcomings, and if possible, promising practices. Our webinar today aims at exploring the challenges for accurate data collection around FGM prevalence in Europe, understanding methodologies currently used in different countries to estimate FGM prevalence and overcome such challenges, sharing promising practices around methodologies for data collection on FGM prevalence, and exploring what potentially would be needed to have a common methodology on FGM prevalence at European level in order to inform related advocacy. Indeed, there's a common methodology to estimate girls at risk in Europe, developed and refined by IGA over the last 5 years. But there isn't anything such as that sort of thing for FGM prevalence. And why is this so? Would it be beneficial? And at what condition could this be possible? We know that the only common basic methodology used so far in studies at European level and in some countries to assess FGM prevalence is pure indirect estimation. That is, applying to the female population living in the country, but originating from countries where FGM is performed. The percentage of the national prevalence of FGM in the country of origin. However, this methodology poses a number of issues. If On the one hand, it has the pro of being potentially replicable in several countries over time, and therefore provides a basis for being a common comparable methodology. On the other hand, it is quite simplistic and not reliable on the results. For example, it is only based on national average prevalence, not considering regional specificities, and also considered official UN prevalence data available for 31 countries. There is a lack of disaggregated data of inclusion of asylum seekers and undocumented migrants in the picture. And finally, a lack of consideration of the potential influence of context of migration on the practice. To look at and face all these issues, researchers have started at national level to come up with potential solutions to align and correct the margin of error and to make sure to have a more accurate picture of how many survivors live on their national territory. This is very crucial and key to inform tailored practice and policies and provide the adequate support services survivors need and require. So enough from me now, and without further ado, I'm going to now introduce our amazing panelists, and I'm going to start with Adriana Kaplan Macusan from Spain. Adriana Kaplan is a professor of medical anthropology, director of the chair of knowledge transfer at the Department of Social Anthropology, Universitat Autònoma of Barcelona in Spain. She is the executive director of WASU UAB Foundation, a strategic project of the UAB. Her major fieldwork has been in Spain and West Africa, mainly in the Gambia, since 1987, on issues concerning reproductive and sexual health and rights from an interdisciplinary, transnational and longitudinal approach. Professor Kaplan is leading as principal investigator the Transnational Observatory on Applied Research and Knowledge Transfer on Female Genital Mutilation, with 2 research and training stations in the Gambia and Spain, developing an innovative, sustainable, evidence-based and results-oriented methodology, replicated in Kenya, Tanzania, and Senegal. Professor Kaplan is a member of the steering committee on FGM at the World Health Organization in Geneva, a scientific member of the Wise Women's Shura Council in New York, consultant at European Institute for Gender Equality (IGE) in Vilnius, as well as the World Bank in West Africa. Amazing. So the question is, you have developed the very first FGM map of Spain in 2001, 20 years ago, to bring to the surface and to the attention of policy and decision makers an issue that was not acknowledged by the general public as something concerning an European country. And way before the big migration flows we experienced around 5 years ago. Since then, you have been updating the FGM maps every 4 years to create what you call the movie on migration and FGM in Spain. In these maps, you decided with a precise ethnological and methodological reasoning, consider the total number of female population living in Spain and originating from countries affected by FGM without applying FGM prevalence rate of the country of origin to it. So now, could you tell us a bit more about this journey that you started 20 years ago and about your specific methodological choice? And what are the challenges you have seen in accuracy of FGM prevalence estimation in Spain? Over to you, Professor Kaplan.
Good morning, everybody. Very happy to be here. And Okeni, thank you so much for the presentation. And really, you put a challenge on all of us, because this is an issue that, numbers always create discussions, rich discussions. So I think that the panel is powerful. We're going to have a very nice webinar. Thank you for the invitation in the name of the WASU team. I will share with you a PowerPoint if I know how to do it. Okay, we're going to present the experience in Spain and try to come to all these things that Okeni was bringing on board. Why calculate the prevalence of FGM? I think that this is the main question, because numbers, but what do we do with the numbers? So in 2001, we started working on this FGM issue in 1987. And in 1988, we started working in Africa in this transnational, way. And we wanted to know how many women and how many girls were in the territory to make the practice visible in the different municipalities, provinces, and regional communities in Spain, to be able to design and implement public policies. It was time to make it visible that the women were here, the girls are here, that there is a masculinity index, a very high one, meaning that, many women will potentially come on family reunion. And that at that time, in 2001, there was a responsibility in terms of politicians, and we needed to make visible the presence of these women and the need to care and do prevention. So also we thought about this in terms of monitoring the progress and to evaluate the impact of FGM care and prevention activities, that NGOs were working on the issue, primary care providers, health, social work, and education, and administrations. How are they doing in the territory? What are they doing? And what is the impact it's having? And then also one of the reasons to start thinking about this was to encourage decision-making to be an informed process, and the policies that are developed are also informed. And then to determine the allocation of resources in prevention, care, and accompaniment of FGM among women and girls with origin or ties in countries where the practice is still alive. So mainly this was what was going on in our minds at the time, to propose, just a first map in Spain, and this was why we wanted to do the map. It's a pioneer in socio-demographic study that identifies the territorial distribution of the population of FGM and origin. So what we mean by this is one that has nationality or was born in one of the 32 countries considered where there is evidence that the practice is performed. As you said, it's a movie, it's updated every 4 years, because we think that the dynamics of migration is so agile and things change so much that to have a picture in one moment in history is okay, but we need to see how these dynamics develop. And we will see why it is so interesting to see this every 4 years. The latest edition was done in 2017 and is based on a quantitative analysis of data from the Continuous Population Register using microdata in 2008, 2012, 2016. And the objective was to characterize this group of the population by sex and age and locate it territorially in Spain by regional communities, provinces, and municipalities. So what we wanted to identify is women and girls aged 0 to 14. So these are the 4 maps. Okay. The maps are about 120, 140 pages. I think that gives us a better understanding of the evolution of this migration in the territory. So according to data from the latest map, 250,000 people resided in Spain from countries where FGM is practiced. And we are talking about total population because we also want to know the masculinity index in prevision of family reunion and women and girls coming from countries of origin. So the comparison between 2012 and 2016 is 2.1 decrease in general population and 5.2 increase in female population. The geographical distribution in Spain, according to 2016, the major region of people coming from, women coming from these nationalities is Catalonia with 31% almost, followed by Madrid and Andalusia. So according to our estimation, you see the comparison between 2008 2012, there is an increase of 41%. And between 2012 2016, we have an increase of 5.2%, meaning that the crisis has stopped family reunion and it has decreased. And in terms of girls, there was an increase between 2008 and 2012 of 64.4%. We need to take in consideration that the fertility rate of Gambian and Senegalese and Nigerian women are the highest, followed by Moroccans and Romanians in Spain. And here is very interesting to see that it has come down to 0.4%. Okay, and we will see why, which is something that we found out without looking at it, which is the beauty of this map. Okay, because I don't think that we will ever come to the exact number of girls or women, but the dynamics is what is important and what we're finding in these maps. So the major population we have is Nigeria, Senegal, Gambia, and Guinea and Ghana. We don't apply the prevalence of the countries, okay? This is very important because this is what makes a big difference between the AGE methodology and our methodology. So the evolution of the population, the women in Spain, you can see that the relative growth, the comparative 2008-2012 is an increase of 41%, and here 2012-2016 is 4%. And it's interesting to see, for example, what's going on in the Basque community. For example, that you had an increase of 134%, and it came to 47%. Still is very, very high, as it is very, very high in Galicia, although it has gone down drastically. And in the other ones, you can see how it has gone down. 40.6%, 5.2%, 2012-2016. In terms of girls aged 0 to 14 in Spain, we see that there has been a decrease in Catalonia of 6%, a decrease in Madrid, and this shows clearly that there has not been family reunion, and the dynamic was send women and children back to the countries of origin because of the crisis and the loss of job. So in Catalonia, I think it's very interesting to see that between 2008-2012, we had an increase of 41.4, and between 2012 and 16, 4.5. In girls, we had an increase of 46.6, but we had a decrease of 6%. And we find out a loss of 404 girls. And this is what I'm telling you, that sometimes this type of maps will show you things, so you will find things or discover things that you're not looking for, but they reflect what is going on in the territory. And this loss of 404 girls in Catalonia is specifically in one province, which is Girona, where for many, many years, the police has been following families getting their passports taken. The girls are forbidden to leave the country until they are 18 years old, and sometimes they need to go through genital checking every 6 months until they are 18 years old. So, of course, this has an impact, and of course, the map is showing, why we are missing these 404 girls. We compare this also with boys, and the number of girls is much, much, much higher. So this is helping us to show to the ombudsman and to show to the judges that this is not the way of doing prevention, that the last thing you do is you persecute families, you follow families in the streets, in the schools, that this is the last thing you have to do, that there is a process, that there are protocols that says that first you need to do sensitization, you need to train primary care professionals, they can do preventive work, they can care of the consequences of the women, and well, you need to train them. And this is something that has not been done. So this has helped us to push and press the politicians to show what the map is showing, okay? And the impact of this wrongdoing is having in the girls. So we need to look for the superior interest of the girls, according to our constitution, okay? So here we see Senegal, Gambia, Nigeria, Guinea, and Ghana. I wanted also to say that, for example, we don't take in consideration the prevalence in the countries of origin, because in the case of Nigeria, for example, Nigeria has, I think it's 25% prevalence, but we know that the Nigerian women, by ethnographic work that we're doing, that the Nigerian women we do have in Spain, they come from southern Spain, they come from Benin City, they're Christians, and most of them are cut. So that's why we don't use it. As by ethnographic studies, we know that Senegalese women in Spain mainly are Peul, mainly they're Fula women, they're not Wolof, and so we cannot use the prevalence of 25%, 26% in Senegal because it's not accurate. In any case, I don't think this matters too much, but for the purpose that we have, we think that it's more honest, because we don't know. It's more honest to give the number of girls or number of women in the territory, and then as a health professional or as a social worker, you can always approach and ask if, in your ethnic groups, this is practice or is not practice, okay? So here we are seeing the UAB Foundation has produced 2 national reports on the situation of FGM in Spain, and this was something done for the government delegation against gender-based violence, who is taking care of all gender-based violence. And the first one we've done in 2012. At that time, we already said there were 6,699 girls. And in the last report of last year, the delegation asked that we should use the EIGE methodology, and we came to 3,652 girls 0 to 14 years. So you see here, maybe is where you can see that, I don't know if it really matters, if it is 6,000 or if it is 3,000. What matters is that there are girls in the territory. And sometimes if we apply prevalence, we cannot talk about the magnitude of the presence of these women, and we are not really talking whether they're cut or they're not cut, because one way or the other is not accurate. We don't know. So that's, we wanted to show the difference of the 2 methodologies. The estimated prevalence of girls at risk, the registers that could be used to generate prevalence data are the medical records of women and girls, which administrative records that are not used effectively, administrative records on the protection of minors related to FGM, asylum cases for reasons related to FGM, criminal records, investigations and prosecutions could give us, numbers, could give us estimates. But the problem is that the records are not used effectively. The data collection is not done in a systematic way. There is missing breakdown of data in existing records. And as Okeni said, the segregated data is difficult to get. Data is not centralized. There is inadequate or non-existent training of professionals who can code and evaluate FGM cases, and there is a diversity of codes and lack of uniformity in the registry. Already about 15 years ago, we have identified some codes that were sent through the Catalan Institute of Health. So, we could have a systematized way of registering, but sometimes it's used, sometimes it's not used, it's not systematically used. Okay? We need to see that there is an overload of work they don't even remember these things. The extrapolation of prevalence data for Africa, population census data on the number of migrant women who come from countries where FGM is practiced, and then the birth records. Problems. Census data are used to extrapolate prevalence data of Africa. The data cannot reflect the recent changes in migrant populations. Asylum seekers, refugees, and undocumented migrants, as well as second and third generations, we don't know how to call them, are often not included, and the ethnic origin of migrants is not considered. FGM depends on the ethnic group that practices and not in the country. So, problem with available records. It is not possible to study the trends and evolution of FGM in Europe given the lack of comparable and reliable data on prevalence, and given that data are not collected systematically over time. This was highlighted by Elsley. The joint shadow report for Spain, there is no national registry that centralizes the number of cases of women and girls affected by FGM in Spain, and it would be an obligation of the government to provide this registry involving public administration at different levels. Sorry. And this in accordance to Article 11 of the Istanbul Convention, and applying certain filters and trying to quantify in detail the population that is at risk can lead to stigma and discrimination against the Spanish population or resident in Spain that maintains ties in countries where FGM is practiced. It can also be used for counterproductive ideological or political purposes. I think that we are in a very dangerous times where the right wing is gaining position and power in Europe, and we need to be very critical with this. Okay, so we need to be careful. The methodology. It is decided to calculate the risk of suffering FGM by province. The statistical calculation is extrapolation of prevalence data from African countries plus the impact factor on the migration and acculturation process based on age. The calculation of the volume of population at risk, number of girls between 0 to 14 by province, nationality, and country of birth, provided by the National Institute of Statistics. This is something I want to tell you that we have in the last map. We have incorporated nationalizations. I mean, they have Spanish nationality now. Okay, so we were missing lots of population that came a long time ago that today they are not by nationality, but by the place of birth, and also, you know, who had the nationality before and who changed to Spanish nationality. Well, I just wanted to show you the risk, go beyond statistics. The use of qualitative techniques for collecting data allow a better approach. The population must be empowered to make informed decisions and generate positive changes that last over time. The realities that surround and perpetuate FGM necessary to approach the issue with due respect and sensitivity. Changes that occur in new trends in practice to identify new formulas and strategies for preventive intervention. Preventive work and the accompaniment of women and girls should be incorporated as one more issue within the normalized circuits in the areas of health, social services, and education, and it goes beyond the exact number of women and girls. Our beliefs from WASU is that if there is only one woman living with the consequences or a girl at risk of being practiced FGM, should be more than enough reason to address this issue properly and with respect. Thank you.
Our next speaker, thank you very much. I'm going to now very continue as well. I think we are very privileged to have now by experts here today. So now I'm going to talk about Fabienne. Fabienne Richard is a French registered midwife who specializes in tropical medicine and public health. She has a 10-year experience as clinical midwife and field experience of 5 years in developing countries such as Afghanistan, Burkina Faso, Kenya, Liberia, Somalia, Sri Lanka. Fabienne is a female genital mutilation expert midwife and is involved in FGM research for Doctors Out of Coordination of FGM Prevalence Studies in Belgium, medicine in action research on referrals for girls at risk, and clinical guidelines writing for the Ministry of Health in Belgium. She is a member of the Superior Health Council Working Group on Reconstructive Surgery Post-FGM. She is currently the Executive Director of GAMS Belgium, midwife at the Multidisciplinary Healthcare Unit for Women with FGM Semavi in Saint-Pierre Hospital in Brussels. She is scientific collaborator at the School of Public Health at the Université Libre de Bruxelles and lecturer in several midwifery schools. She is coordinating the EU project Access 2018 to 2020, December, which aims to improve the access of victims of gender-based violence to support services through trained community peer educators and an awareness campaign. So the question is, in 2007, the Belgian Ministry of Health commissioned you a study on FGM prevalence, while two following studies was conducted in 2012 and 2016, supported by the Institute for Equality Between Women and Men. Over the course of the years, you have refined that methodology used, and in the last study, you tried to overcome the methodological limitations of indirect estimates by looking and considering additional variables. For instance, age of arrival, and by including new portions of the female migrant population not previously considered, such as those in an irregular situation or those having been granted asylum due to FGM. You define your methodological approach as very operational, looking at the study as a mean to identify the sectors of population in need of adequate services to inform consequent advocacy. Could you please, let us know or tell us more about how you are applying these new variables in your methodology and why you think they improve the accuracy of FGM prevalence estimates for the operational purposes that you had identified? And what are the limitations of your methodology, and what do you think will be needed to overcome them? So over to you, Fabienne. Thank you.
Thanks, Stokes. I think you did already a nice summary, so but I will go ahead. So yes, the last study in 2016 was the first study, prevalence study in Belgium with the same methodology, but as you said, we try to improve every time we do a new study. Can I? Okay. So, as Adriana said, for us also it's important to ask us the why we need these numbers. We don't want only the numbers, we want to be really operational, and for us this number will help us to see the needs for the medical and social services in Belgium, which deal with female genital mutilation. And as you know, in public health, we don't have enough money, and we need to see why we need to put some human resource or financial resource to FGM. So we try to have a steering committee quite broad with people from asylum seeker centers, doctors of the world to have access to undocumented people. So the Ministry of Equality, Ministry of Health, we work also with birth data, so it was also interesting for us to have the Office of Birth and Childhood to have a second generation. So we try to be really comprehensive. So it's an indirect method still, even if we try to improve, it's not a direct one. Huh? So the first phase, as you know, is to estimate as precisely as possible the female population originating from an affected country. So it's like the phase of Adriana, it's the same. We have a first generation, but we were able in Belgium, I know all the country can't do that, to have a second generation. So through the data of the Office of Birth and Childhood. And the phase 2 was to apply the prevalence. So we did apply the prevalence, but we didn't apply the national prevalence. We tried to be a little bit more precise by applying the age group. So we use the DHS and the mixed studies. So regarding the different source of data, we have first the register of population. So we are quite lucky in Belgium because I know, again, all the country don't have a register of population. You have either a census of population or a register. And for us, it was, we can say more easy with a register of population. So we could have a female population originating from one of the country where FGM is practiced. And we had also the asylum seeker. So we were, because the asylum seekers are not yet in the register of population, so we could add them from the data from FEDASIL. FEDASIL is the national agents of reception center. And undocumented people, we could have them an estimation from a Doctor of the World. So Doctors of the World of Médecins du Monde in French is an NGO working with undocumented people. So even if not every woman go to the services of MDM, it was the first time that we included undocumented people. We didn't want to have several NGO because we wanted to avoid doublon that we count for 2 times or 3 times a woman who will go to several NGOs. So we choose the biggest one. We add the second generation, so with the birth data. And first time also in this study that we took into account the international protection on FGM, because in Belgium we have a lot of girls. We got a protection on the basis of FGM. So these girls, this group, we can say they are really protected. They will not be cut. So we were able, with this estimation, to have our population of reference. So this number could be the number of Adriana, is the base for us. More than 70,000 girls and women are originating from an FGM country. And then we apply the DHS by age group, and at the time, when we apply the last DHS and mixed prevalence that we could find, not all the study of DHS had an estimation on the 0 to 14. Now it's more frequent to have the 0 to 14 year, but the oldest DHS study, they have only from 15 to 49. So we applied the last age range when 0 to 14 was not available. And we, above 50 years, we also used the most close age range that we have, and it was the 45-49. So what did we do new from the last prevalence? We add the new data on Indonesia because last time it was not available, the numbers of Indonesia, the prevalence. We add the data on undocumented migrant from doctors from the world. We use also the age at arrival. So in the two studies done in 2007 and 2012, we didn't have the age at arrival, and this time we add this data from the register of population. So we were able to make different hypotheses, and I will present you the hypothesis. And we use also for the first time the numbers of girls protected by the international protection on the basis of FGM. So you see in Belgium, we have we had at this time 1,800 girls protected, who were granted as refugees on the basis of FGM. Among them, 100 were cut already, who had already FGM, but 1,700 were still intact. So this one we can say they are protected. The three hypotheses. So we had the high estimation, low estimation. So we use the age of arrival in the hypothesis and the fact to be granted as refugee on the basis of FGM. So the high estimation is when we say that all the girls born in the FGM practicing country have most probably already undergone FGM. So you see in the vocabulary, we use always have most probably because it's not a direct method. So we want to acknowledge that it's an estimation. All the girls born in Belgium or another not practicing country are intact, but are at risk of FGM if no prevention work is done. So I know that we had a big discussion with Claudia Kappa, so the researcher who did the study with UNICEF, how we should call this category of girl at risk. I know it's not the debate today, but with her we say, yeah, they're at risk, but of cutting if no prevention work is done. And for us is really the way also we see this like a target group of prevention. We know, of course, unfortunately, that not all of them will be cut. It's not the reality, but we see them as a target group for prevention. Medium estimation. All the girls and women arrived in Belgium after the 5-year anniversary have most probably already undergone FGM, except the girl who obtained an international protection. So it's always the age that changes. So the low estimation is the same, but the threshold is 10-year anniversary. So I know there's some method where you use the medium age of cutting in the DHS, but for us, we prefer to be simple by using 5 and 10 because we know that with the migration that the age of cutting doesn't apply really, because a mother, for example, who wants to protect her girl or girls, she will wait the opportunity to leave the country. So she can protect her girl maybe longer than the medium age, in fact. So we thought that it was better, anyway, we don't know, that to use 5 and 10, and to say that the reality is between the high and low estimation. So we work a lot also with a specialist in how to disseminate the numbers and the result of research to visualize, to how you can show it in a way that people understand. So we try to present like this our population of reference you see above, and under the result after we apply the DHS age range of FGM. And again, we were able to present the trends as we did the study 3 times in Belgium. So it was the first time we had the 3 hypotheses. So you could see that in the 2 first one, we didn't have the 3 hypotheses because we didn't have the age at arrival. And we try also, because as we say, we want to be operational and to see where we need to put the resource, that we try also to present the result by provinces in Belgium, and like this we use it for the training of professionals. With this map, the MOH was able to say, okay, we start the training of professional gynecologists and midwife in Brussels, Antwerpen and Liège, because it's the most affected provinces. And we were also able to show which country were the most represented. I think it's important in Belgium to see, when I will explain in a few minutes the limitation, because we know that limitation is because we don't have ethnic group. It's difficult to see the impact of migration. But as you see in Belgium, the two first big group, and the first one is really Guinea. Guinea-Conakry and Somali, they are high prevalence countries. So in fact, we can't do a lot of mistake with Guinea and Somali by applying the prevalence, because the prevalence is so high. It's 97%, and it's confirmed by the examination, because we work also with a gynecologist, that women from Somali and Guinea who arrive as adults in Belgium are undergone FGM. So we can't do mistake on the two first ones. After, of course, for the country like Cameroon or Uganda, you should be careful. What we did too, it's we calculated also the number of delivery, again with the indirect method, but it's also to show the number of women with FGM who will deliver every year, to see also the needs of training for gynecologists. But we push at the same time the MOH to have a direct registration by having a registration at delivery on FGM status. So this is something we are pushing to. So on the same way, we do the indirect method, but on the other side, we push also MOH, and they have program now in a hospital where it's mandatory when you deliver to have the status of FGM in your file in order to cross-check the data. Asylum seeker, again, for us, if we want to be operational, it was interesting to know how many women in need in the reception center, because we work also with a professional working in the reception center, how you identify a woman with FGM, how you can accompany her in a trajectory of asylum seeker to get international protection for her, for a girl. So this was also important to know these numbers. So I will finish, this my last slide. So it's an indirect estimation, no clinical, and of course there's a lot of limitation. And we know it, no data about ethnicity, why it's very determinant ethnicity. But as I say, it's okay for countries with high prevalence. And as you saw, the two biggest groups in Belgium, it's Guinea and Somalia. It's why we say we think that for us at the moment it's enough. And we don't have maybe the exact number if it's more 50 or less 50, but we have the biggest group to make some decision with the MOH. So we should be more careful with countries like Cameroon, like Uganda, because we know we can do more mistake on this country, but for us it's not really a problem. No prevalence from country with a Bora community like India, like Pakistan. So surely we have forgotten some country, but they are not the most prevalent. And difficulties to estimate the impact of migration. But again, we don't want to be, because we will never know. For us, it's a black number, like the number of girls cut during holidays. It's a black number. We know that there is some case because we saw it during consultation, but it's very difficult to know because it's punished by the law, and no one will say, I went in Guinea, in Djibouti during holidays to cut my girl, so it's really difficult to know. But at least we have a target group for prevention. And for us, as Adriana said also, we need to talk with the mother anyway. If you come from Senegal, it's not written on you front that you are from a cutting community or not. So anyway, when we train the professional, we trying to talk with the parents and to estimate the risk. So it's why we consider this more like prevention group, target group for prevention.
Thank you very much, Fabienne. I will now which is Livia Ortensi. She's a senior assistant professor in demography at the University of swiftly to our next expert, head of the statistic unit of ISMU Foundation in Milan, Italy. She is associate editor of BMC Public Health. Her primary research interests include migration and gender studies. In the field of FGM, she participated in several studies on African and European countries, including 2 rounds of studies on risk estimation founded by IGA and authorized several peer-reviewed studies published in international journals on the topic. So now going to the question. In 2010, the regional government of Lombardy commissioned a study to have direct estimations on the phenomenon of FGM among migrant communities or population as well on the territory. The same request came again in 2017 and 2019 from the Italian government. Throughout the years, you improved the pure indirect estimation methodology by adding direct estimation of prevalence for some specific communities through a combination of interviews and statistics, as well as trying to correct the national prevalence rate in countries of origin by separating the migrant population as a selected population compared to non-migrants. So, Livia, could you please elaborate a bit more on the key innovative elements of your methodology and in which way do you think they improve the accuracy of FGM prevalence estimates? Also, what do you see still are challenges and how could you improve your estimate even more? Over to you, Livia. Thank you.
Thank you for inviting me. I want to say that the work that I present today is the work of a wonderful team which is based across the University of Milan and Bologna and is led by Patrizia Farina, that is here today. In this team, I'm mostly in charge of the methodological aspects. And today I want to focus especially on the topic of prevalence estimation. So all the work that Fabienne presents is of course also an issue for us, and I really appreciated that she presented, so I can focus more on the issue of prevalence. But of course, once we have estimated the prevalence, it remains the topic of the data that to what data I can apply this prevalence. So today I will focus on the issue of prevalence. So in the next slide, I will go very. I don't know if Thank you. I won't be I won't go too much into the history of our studies, but very shortly, the story began in 2010 when the regional government of Lombardy asked Patrizia to be the PI of a study of FGM among migrants in Italy. Then we were part of the Daphne project led by Elsleie in 2015-2017, and in 2019 the Italian Department for Equal Opportunity asked Patrizia again to be the leader of a national study. What I will present today, in next slide, is the best combination. It's not really an excursus of our studies, but is, I think, the best proposal we can present today as a result of our experience. So when we do, the last study we did, we base our estimation on a combination of direct and indirect estimation, where we have direct estimation for the main communities that are settled in Italy, and indirect estimation for small side communities that we cannot reach because they are too fragmented and too few women in Italy. There are also communities that are very small. As for the direct estimation, which is, I think, the more intriguing part. So in the next slide, please. We have several issues while we have to put in place a direct estimation. The first is how we select communities. And how we found women in practice. I have to say that we rely on a long experience in surveys targeting migrants, especially hard-to-reach populations, so including undocumented migrants. So when we started elaborating our methodology, we started from a deep knowledge of how to reach migrant population in practice. The first thing that you ask is how we choose the population that we want to survey directly. And here we changed the idea through the years. In the first place, we started with a community with the highest expected prevalence. And then this was also combined with, of course, the most choosing the most relevant communities, because there are high communities with very high expected rates according to DHS and IMS mixed data, but maybe there are small communities. In the end, in the last surveys, we decided to target also community with a low expected rate. This is because years we considered that in case we had some communities with an higher than expected prevalence among communities like Ghana, like Cameroon, that are expected to have a very low rates, but are very big in Italy, we might not account for a lot of women. And of course, you have to deal with your resources. So this kind of surveys are very costly. So you have a limited number of interviews that you can do. So the balance is that you can add as long as most communities, as long as you can provide a number of interviews that is reliable. So it's a balance of choosing the most big communities, those with an high expected rate, but not only, and to have a reasonable number of interviews per community in your sample. The second point in the following slide is how do we allocate, once we have decided that we cover, let's say, 9 communities and that we have 2,000 interviews possible that we can do, how do we allocate the number of interviews across community? Here we elaborated a method that we call the two-step dynamic allocation of interviews. The idea is roughly this. We split the sample into two. We start allocating the first half of the sample in to our subgroup. Only half of the sample, trying to control the expected error. So we try to have an error that is no more than 10%. So in this way, we will have a higher number of interviews for communities that have an expected prevalence rate around 50%, which that has a higher variability. We carry out the first half of the field work. Once we have collected the first half of the sample, we go through our results and we evaluate the prevalence on the field on this first half of the sample. And then we reallocate the remaining interviews in the second half of the sample according to this prevalence that we have on the field. In this way, we can correct if we find on our territory a prevalence that is very different from the one that we expect according to the DHS, and that maybe needs more interviews to see if it's an error or is something that is really correct. We can allocate the remaining part of the sample in order to refine the estimations. So our allocation of the sample into of interviews to communities is dynamic, and it's the result of 2 steps. In an ideal path of a survey, we have chosen the communities. We have allocated the first half of the sample to each community. So I know how many interviews do I have to do for, let's say, Egyptian and Nigerians and so on. And then how do we reach the women in practice? Especially in the last study, we relied on the center sampling method. I will not go into details, but I can answer after on about this. It's in few words a method that doesn't need any sampling frame, but requires the knowledge and the access to some centers, where centers can be really centers like health centers, or also informal centers like weddings, parks, private parties, and so on, where women can be found. And we reach women going and accessing these centers. Then our method uses some weights to correct our sample. There is a methodology specific, and the result is similar to a probabilistic sampling. And this is the standard method that we use in our annual survey that we conduct in Lombardy every year, and that is founded by the region. In addition, another key point of the methodology is to use as interviewers, cultural mediators, and professionals interviewers that have the same background of the targeted communities. This is to ensure that it's easier to talk about this kind of topic that we know it's very difficult to approach, and to also have an easier access to centers that maybe are just for the communities. So it's easier to contact women using, and also there is the issue of the language. So maybe the women cannot talk in Italian, so we have women that can talk in the native language. Another point is how do we measure prevalence? Of course, once we find the woman, we start with a quantitative survey, which has many questions, but the key question is, of course, have you experienced FGM? And we know that sometimes the answer is not so clear to women, because in some cases they are not really aware. So we leave women the possibility of expressing a certain grade of uncertainty, and we base our estimation on this answer that provides also some degree of uncertainty. So if a woman tells that she thinks that it didn't happen, but she's not sure, we will have a 0.25 probability of FGM on this person, and 1 if she's sure that that happened, and so on. And this is the few words, the way we do the direct estimation. At the end, we have results from a survey. The second part is in indirect estimation, and our starting point is the selection hypothesis. And of course, the indirect estimation can be done on all communities, but we do that only for minor community. But the starting point is that, as has been said before, that migrants are a selected population compared to non-migrants. In terms of typical regions of origin, education, age, and wealth. And we know from DHS and MICS data that these same characteristics correlate with FGM prevalence. So extrapolation of the national prevalence can be highly biased when we apply it to migrants. Our technique is, it seems difficult, as you will see in the next slide, there is a formula, but the idea is very simple. We use the HS data from the report. We try to extrapolate what is the difference between the national survey and the prevalence among all the women and the prevalence among the youngest, those living in urban surveys, in urban cities, the most educated and the most rich. And we try to see how the prevalence change, and we use this change to correct the national survey in an indirect way. And there is a paper on demographic research that has an associated Excel file that allows the replication of our calculation. And in the end, you with a number of coefficients that you see in the next slide, and you can correct the expected prevalence in direct way, but in a way that is expected to match the selection across migrants. And we see that usually we result in an expected reduction of the prevalence, but there are cases like Mali,
1 more minute,
sorry. Yes, Mali and Liberia and Nigeria, where the prevalence is higher. So I have two slides left. In the end, we merge the methods and we apply to data. And a plus is that when you use the direct estimation, you can also inquire things like intention about daughter's cutting, FGM status of daughter, and support to the practice that you cannot infer in an indirect way. And in the last slide, we see the comparison across indirect and direct estimation. We see in few words that in some cases, correcting the prevalence results in a number that is within the variation provided by the direct estimation. So the two numbers are comparable. And in some cases, for example, for Nigeria or for Côte d'Ivoire, we have a situation where the correction goes in the right dimension. For example, the typical case is Nigeria. In Nigeria, if we use the selection hypothesis, we expect that the prevalence among migrants is higher than the national prevalence. But if you go to the field, you find out that the prevalence is much higher than this correction. And this is because there is a selection, a territorial selection of the flows that brings in Italy women from the south, and these are women with a very, very high prevalence rate across 70%. So in the end, what are the lessons learned and the take-home message? Of course, doing indirect estimation in the last slide, please. It's difficult. It's costly. You have to put a lot of efforts in doing field preparation. You have to build an outstanding team of reviewers. We found some differences, some difficult to survey in the survey of communities with an expected low prevalence rate. For example, for Ghana and Cameroon, we had mixed results across the surveys. We think that direct estimation is, if possible, is advisable because sometimes you find that the prevalence in your territory is very different from the one that you find in the country of origin, but the selection hypothesis is a good way to correct the prevalence in case you cannot do a direct survey. Another way, and here I pass the floor to Ramin. Another way is if you have very high quality official data, for example, by region of birth, you can, in my opinion, reach high and variable results in terms of prevalence estimation. So thank you. In the last slide, we have some references, and I am available to share with you if needed. Thank you.
Thank you very much, Livia. And now we move on to our fourth expert today. Thanks for your patience, Ramin Kawous. Ramin is a PhD candidate. Hopefully you can put your slide on. Ramin is a PhD candidate, as I was saying, on female genital mutilation at the Department of Public Health of the Erasmus Medical Center, Rotterdam. He is also a senior researcher at FAROS, Focal Point Female Genital Mutilation. Kawous was principal investigator of several studies on FGM-C, among which the National Prevalence Study of FGM-C in the Netherlands. Ramin graduated from Leiden University with a master's degree in methodology and statistics and a master's degree in social and organizational psychology. So we go to the final questions for our experts. Well, there'll be others hopefully later. You conducted the first study in the Netherlands on FGM prevalence in 2013 and the second one in 2019. Your methodology at Faros consisted in improving the pure indirect estimation by adding a direct estimation methodology through specific age and regional estimations before and after migration, which was possible due to the existence of data on birthplace in Netherlands, corrected then with the level of acculturation and taking into consideration the legal and prevention context in the Netherlands around FGM. So please, could you tell us why you did decide to use these new corrective elements in your methodology and describe how they improve your FGM prevalence estimates? And what are the key challenges to accurate prevalence data and how could they be overcome?
Thank you, Docs. I'm very happy to join here and thank you for inviting me to discuss this topic with excellent colleagues. So I will keep it very short and focus on methodology of our research. The key elements of direct and indirect estimation have been discussed by Adriana, Fabienne, and also Livia. And presenting two studies that we have conducted on FGM prevalence. And I was very fortunate to publish this paper with Livia as well. So we have conducted our second national prevalence study in 2018. So as you see, the main variables were birthplace, age upon arrival, current age, and generation. And we, Statistics Netherlands, provided these data, but we also use data from reception centers on female asylum seekers, which have been added to data. Unfortunately, there was no data on undocumented migrants. So no undocumented migrant data have been used. So this is our main variables, but we also in this study included migration and acculturation as a reduction factor, but also the preventive measures. So we have this Dutch approach to battle FGM to systematically provide information to communities affected by FGM. So it is reasonable that they have been to some extent protected. So we use these preventive measures as a reduction factor and also the acculturation factor. Using these two variables, migration and acculturation and preventive measures, we conducted a sensitivity analysis to see what these two factors does with the numbers, with the estimates. So next slide, please. So this is a very important chart for us. So identifying the relevant population and subpopulation was very, very important because these population and subpopulations are based on assumptions. And we, so the study population was about 95,000 people. We divided it by first and second generation. And this variable was also provided by Statistics Netherlands. And we use age and upon arrival to distinguish groups that which contribute to the prevalence, but also to the risk. So the dash, the solid boxes are those which contribute to prevalence, and the dash box are those which I'm not discussing now here, are those girls 19 years old and younger who contribute to risk. So that's in the women from asylum seeker reception centers are not shown here, but they were also added to data. So that was it in short, and you can read more on this on our recent paper, which has been published this year, and I'm happy to discuss your questions later. Next slide, please. So we also conducted a second study last year so it was a nationwide survey of all midwifery practices in the Netherlands. So that was about 600 midwifery practices in the Netherlands. So we compared this data, this study on the prevalence. So that is a direct estimation, and the previous one was indirect estimation. We surveyed all midwifery practices on FGM, but we also asked Statistics Netherlands to provide us data on migrants who gave birth in 2018 in order to extrapolate these data to women giving birth. So we did this to compare our direct estimate of all midwifery practices with indirect estimates of women giving birth. So in the nationwide survey, we asked the midwives to provide us with the number of women who received care during pregnancy, birth, or postpartum, and the number of women with FGM who received midwifery care. And these two variables helped us to estimate the prevalence of FGM. And this paper has been published also this year. So that was very, very short and very brief. And I'm happy to discuss with you now and with other colleagues your questions. Thank you very much.